Chapter 15, Assessing the Peripheral Vascular System and Regional Lymphatic System. Functions of the peripheral vascular as well as lymphatic system. The body is a complex organ that requires many systems to function and interact together. The peripheral vascular system contains an intricate system of arteries and veins, and lymphatic system carries lymph fluid throughout our circulation. Arteries are narrow, thick vessels that transport oxygenated blood away from the ventricles of the heart to every part of the body. Arteries branch off into smaller segments called arterioles, very similar to the bronchioles, branching off into the bronchi, branching off into bronchioles. This is the same concept. And the arteries are made up of 3 layers, strong layers, because you have the oxygenated blood flowing through them. You have the tunica adventitia, the media, and then the intima. Veins are opposite. They carry deoxygenated blood, usually are unidirectional, have unidirectional valves to prevent backflow of blood. So a lot of these you'll notice in the lower extremities, preventing backflow of blood. And as a patient gets older, those valves start to weaken up, and that's why they're at a higher risk for edematous, because the blood starts to backflow. Veins in the upper extremities carry deoxygenated blood to the right atrium of the heart, and veins in the lower extremities carry deoxygenated blood to the inferior vena cava. So both the superior vena cava and the inferior vena cava drain into the right atrium of the heart, or the right side of the heart. The lymphatic system comes, or the lymphatic comes from the Latin word lymphaticus, meaning connected to water, right? One-way upward flow system that has 2 major ducts, the right lymphatic duct as well as the thoracic duct. The lymphatic system includes the spleen, the thymus, which is near the thyroid, trachea, bone marrow, tonsils and adenoids, your appendix, parts of the liver as well as lungs, your lymph nodes, and an example is the epitrochlear node located right near the brachial region, and your inguinal nodes located near the femoral region of the lower extremities. And there are also Peyer's patches located in the small intestine. Lymph nodes are networks of fiber and irregular channels that slow down lymph flow. As lymph fluid passes through the nodes, fibers filter out bacteria, viruses, and cellular debris. And there are over 450 lymph nodes present in the average human body. And remember, when we talked about HENT, a vast majority of those lymph nodes are located from the scapula and the clavicles up to the top. So you got your periauricular, prostauricular, occipital, and your tonsillar, and then your clavicular chains. There are many diagnostic studies that assess the peripheral vascular as well as the lymphatic system, including a CT scan, an MRA, an angiogram, angioplasty, as well as a lymph node biopsy. The angiogram is an imaging X-ray that uses a special dye to visualize blood flow through the arteries as well as veins. An angioplasty is a balloon placed in the blocked area, and it's inflated in order to break up any plaques that are located within that vessel. So what are the thinnest and most fragile parts of the arterial system? Are they capillaries, arteries, veins, or venules? If you said capillaries, you're right. If you said liver, the entire liver, you're correct. When collecting a health history, we want to make sure we are collecting a focused health history regarding pain, swelling, edema, lumps, or skin changes of the extremities, specifically the lower extremities. And as discussed, we want to use the old carts, PQRST, mnemonics to kind of help identify the onset, the location, characteristics of pain, if any, characteristics of their swelling, pattern, time of day, any associated or alleviating factors, and what have they done, as well as the severity of the pain if they're presenting with pain. We want to collect a history on whether or not they've been diagnosed with peripheral artery disease, whether they have any pain, tingling, or numbness, especially in the lower extremities, and when does that happen? Is it when they're walking or when they're asleep? And then any intermittent claudication, which is simply pain in the legs. Ask about aching, burning in both the legs as well as the feet when at rest, because that can indicate arterial complications. And then assess for edema or swelling of the lower extremities. We also want to ask them about their risks for lymphedema, and I want you to specifically look at box 15.1, which is located on page 276. And risk factors for lymphedema really include family history. Obviously, genetics is a big part. Any removal of lymph nodes where that fluid has no place else to collect but within that area. Any surgical procedures, radiation, chemotherapy, or morbid obesity, which can prevent blood as well as lymph from traveling back up to the heart. We want to assess for any skin changes of the extremities, rubor, which is a really red, rusty coloration to the lower extremities. Elevational pallor, when you're raising up a leg, does it become more pale? Is the blood drain out of their extremity? Any changes in their texture of their skin? Loss of hair. Loss of hair can indicate deoxygenation of that extremity, usually related to arterial disease. Raynaud's, or are there any wound or skin ulcerations to the extremity? The patient reports that he has sharp cramp-like pain in both legs when he walks. What should your next question be? If you picked B, you're correct. Identify how far or what activity aggravates the pain. Intermittent claudication, again, is a symptom of peripheral arterial disease. It's just cramp-like pain due to decreased blood flow and oxygen to the legs. When conducting your objective data collection, you want to go from head to toe, and you are really using inspection as well as palpation. Percussion, and you may use some auscultation, but inspection and palpation are your major nursing skills. Provide a comfortable room, temperature, assist the patient to change positions if needed, and then remove any clothing that might impact your visualization of their extremities. So starting from head to toe, again, we talk about assessing lymph nodes. You want to assess the lymph nodes of the head and assess for any enlarged lymph nodes. The patient should be sitting up. The patient's neck should be slightly flexed, maybe forward, just to give him a little, give you a little more angle to palpate. And then you want to use the pads of your fingers in a circular motion. Again, you want to ask the patient to flex their neck to the right, shrug their shoulders to kind of help bring those lymph nodes out. And then you want to palpate all of the lymph nodes, pre-auricular in front of the ear, post-auricular behind the ear, occipital behind the head. Your tonsillar is right underneath the earlobe, and then you're moving down the superficial, deep cervical chains, and then your supraclavicular angle around the clavicle. And you differentiate between normal as well as abnormal findings. And this you can also find on table 15.1, which is on page, and I'll give that page number to you, 278. When you're assessing lymph nodes, you're assessing their size, consistency, mobility, as well as tenderness. And these are the lymph nodes that were just discussed. Oh, submandibular and submental is right in the middle, submental. Normal findings, our lymph nodes are palpated. No lymph nodes are palpated, although if a lymph node is palpated, it's usually less than 1 centimeter. It's not tender, it's movable, and it's very tiny. And some patients, you might feel a little tiny lymph node, and that's just part of their anatomy. Anything that's abnormal is usually greater than 1 centimeter, hard, and very tender. And sometimes that can be related to an infectious process in that area. When assessing the lymph nodes, when you're assessing the carotid rather, you have your carotids right on the lateral aspects of the trachea. And you want to ask the patient to turn their head from side to side to really palpate. And you want to do it one at a time. You never want to do them together at the same time. You never want to do them simultaneously. You always want to do one at a time. And you're using your finger pads. And you're assessing the rate, the rhythm, as well as the amplitude. And the carotid pulse should match up with the apical pulse, as well as the radial pulse and the brachial pulse. Normal findings include visible symmetrical pulsations, rate 60 to 100. If they're have more active lifestyle, it's usually closer to the 60 range, maybe 50. 50 can be normal for a person. Again, well-conditioned athletes are between 40 and 60. Rhythm is regular, amplitude is about +2. It's not bounding and it's not thready. Auscultating the carotid arteries, you're just assessing. If you have an abnormal carotid assessment, then you want to auscultate with your stethoscope and assess for any swooshing sound or bruise or blowing through that vessel. And usually these are patients with high hypertension, cardiovascular disease. Auscultation should be a part of your assessment. And again, when doing that, you want them to take a breath in, hold it so that you can listen to the sound, and then use either the bell or the diaphragm. And usually bell is easier to use just because of the smaller surface area. And then again, normal findings when you're auscultating the carotid is you don't hear any bruise. You're doing a lymph node assessment. What lymph nodes are located between the back of the head and neck? We would consider those the occipital or the suboccipital lymph nodes, right in the middle, right at the angle of the back of the head between the two parietals, right above the occipital. I'm sorry, right below the occipital. That's my mistake. You're assessing a patient with long-term peripheral artery disease or arterial disease. He is sitting on the side of the exam table and you assess that his legs are turning red, bluish, purple. What should you do next? Knowing that they already have peripheral arterial disease, this is actually a finding of this disorder. Inspecting for your jugular venous distension is only to assess for increased signs of increased central venous pressure, more so congestive heart failure, right-sided heart failure. For this assessment, you'll need lighting, good lighting. You can use a pen light as well. You need an index card as well as a ruler. And you'll have the patient sitting in an upright or a semi-Fowler's position. By using the lighting, you can inspect the right side of their neck, note for any pulsations, and then you can assess the left side of their neck. Normal findings, no abnormal pulsations. Abnormal, you would start to see a distension. Inspecting and palpating the upper extremities. You want to assess for peripheral circulation. Use a paper measuring tape. And then you're inspecting each arm from the fingertips to the shoulders. And you're looking for symmetry, coloration, changes in color, and you're actually comparing and contrasting one extremity to the other. Feel for texture, dryness, anything that feels abnormal, and you're also assessing for edema. You're closely inspecting the fingernail beds of both hands, looking for nail coloration, nail thickness, and a profile sign. Using the dorsal surface of your hand, right, the back part of your hand, you're just feeling for the temperature. Okay, both sides. And just doing it symmetrically will allow you to compare if one extremity is cooler or warmer than the other. As part of your upper extremity assessment, you're also assessing the epitrochlear lymph nodes. And again, you're just assessing the lymph nodes right behind that brachial region, right lateral. And you're assessing pulses in each arm by gently placing your second and third finger pads of your dominant hand and assessing the radial pulse, which is near the thumb region, as well as the brachial pulse. And the brachial you should recognize because you learn that when you're conducting your blood pressure assessment. Normal findings. Arms are symmetrical, color is uniform, there's no evidence of edema, no areas of ulceration. Fingernail beds are pink, and if you have nail polish or gel, you can always look at the pads of their fingers and do capillary assessment. No abnormalities with their venous pattern. Their fingernails have even thickness. They're not clubbing or thickening over, usually related to deoxygenation. That's very common when long-term smokers, you'll start to notice a thickening of their nail beds. And the fingernail has a 160-degree angle of attachment. When you're assessing the lymph node, the epitrochlear nodes, you don't feel anything. Their temperature feels warm, and their pulses, both radial as well as brachial, are +2. And these would be considered your abnormal findings. And then you'll be assessing for edema, and usually that's done for the lower extremities, and edema is just an accumulation of fluid seeping into the tissue. It usually has no place to go. It can be pitting, or it can be non-pitting. Peripheral edema is usually an accumulation in the legs as well as the feet. All right, and this also could be a couple of different complications related to this, but sometimes it's related to weakening of the valves located in the veins and preventing fluid from normally traveling up, blood normally traveling up to emptying into the inferior vena cava and into the right side of the heart. When you're assessing, you want to gently apply pressure with your second and third finger pads on the edematous area. Start from the feet and work your way up to the tibial region. And you can grade it based on a scale of 1 to 4. 1 is slight pitting, where 4 is deep pitting. Hear my dog in the background. You are auscultating the right carotid artery for bruise, which is that blowing sound through a vessel. What instruction should you give the patient? If you answered C, you're correct. When assessing capillary refill, do it from the finger pads. You're just simply assessing for perfusion of tissues. Normal findings is that when you press in and let go, the pad of the finger returns to pink, and it takes about 1 to 2 seconds. Anything greater than 2, and you do it not only for the fingers, but you do it also for the toes. Anything greater than 2 seconds is an abnormal finding. It's just meaning that the vascular system is taking longer to perfuse that extremity. When inspecting and palpating the lower extremities, you're simply going to follow the same format as you did with the upper extremities. You'll need measuring tape to help measure the extremities, especially if there's evidence of edema. And you also can use a handheld Doppler to assess for sounds that you might not be able to feel. If you can't feel a pulsation, you can actually listen for the pulsation using the Doppler. You want to position them in the supine position, expose the lower extremities, and assess for symmetry, color, texture, edema, as well as venous pattern. Very similar to how we did it for the upper extremities. Inspect for hair distribution, ulcerations, inspect the toenail beds, look for capillary refill, look for coloration, changes in color, paler, ruber, thickness of the nail beds, assessing temperature using the dorsal part of your hand. You should use gloves when assessing the lower extremities. Use the second, third, and fourth fingers and gently palpate their left as well as right inguinal lymph nodes. Assess for femoral pulses as well. While you're checking the lymph nodes, also assess for pulses. And you're assessing for the popliteal pulses, which are located behind the knee. There's 2 ways you can do it. You can do it when they have their knee bent up, kind of cup their knee, or you can just use the finger pads and press against the back part of their knee. The dorsal pedalis, which is the top of their foot, and then the posterior tibial, which is right behind the malleolus, that curvature behind the ankle. Each pulse, again, you're assessing rate, rhythm, amplitude, symmetry, matching on both sides. And normal findings include symmetry, uniform coloration, no evidence of edema or ulcerations, pink toes, warm temperature, and even distribution of hair. Lymph nodes are not palpable, the pulses are +2, and the veins are not distended. And these are abnormal findings. Arterial as well as venous insufficiency wound. Your table 15.2 has a great kind of appearance, as well as common locations, as well as descriptions between those two. So I would highly recommend that you focus on that table when learning to differentiate between the two. But arterial, usually they have more of a punched out, round, smooth, defined ulceration, where venous ulcerations usually are irregularly shaped, unevenly shaped, very shallow in location. Abdominal aortic aneurysm screening, it's important to include this in your assessment, and usually one-time screening by ultrasound is done in men between the ages of 65 and 75 who have a history of smoking. But it's not recommended as routine screening in women who have never smoked nor have had a family history. When performing the Blanche test on an 85-year-old patient, and that's just simply pressing on a nail bed and releasing, your assessment finding is 6 seconds. What is a normal finding? If you said A, you're correct. And then last question. The RN is assessing a patient with bilateral lower extremity edema. The depression is about 6 millimeters in both lower legs that lasts more than a minute. What will the nurse document? Is it +2, +2 non-pitting, +2 pitting, +3 pitting in bilateral lower extremities, or +4 pitting in bilateral lower extremities? And if you go to your book,